Now, if we look at case number 41, this one is very much obvious. Now, in case number 41, the notable finding that you can see here is that there's a case of pulmonary arterial hypertension. So this person, he has a high pulmonary arterial pressure and he has severe pulmonary arterial hypertension. So how does it appear on chest x-ray? When there's so much blood that is basically expanding the pulmonary blood vessels, which are found in the hilum, by the way, you will have the appearance of this bilateral pleural hypertension, bilateral pulmonary hypertension. And notice how they look different. They look different from hilar lymphadenopathy. They're much bigger in appearance. They're not lobulated in appearance. They're much bigger and they're going outside. They're going elsewhere. They're going periphery. They're going concave in appearance. So this suggests to me, especially if you have a patient history and patient's examination, especially if we have a loud S2, for example, this is a case of bilateral pulmonary arterial hypertension. It can be idiopathic, it can be due to COPD, it can be through a whole bunch of number of things. But this is a case of pulmonary hypertension, all right? Very obvious. Now, if we look at this case, this is the same case or a very similar case from what we mentioned before about what we mentioned before about bronchiectasis, about interstitial lung disease. So again, this is a spot diagnosis. We can see there's a spot diagnosis, a case of interstitial lung disease, suggesting here that we have multiple cystic lesions or multiple cavitary lesions. They could be in the form of honeycomb appearance. They might not, but we're going to assume this is a case of interstitial fibrosis present within the right upper lobe with deviation of the trachea. We need to order in this case a chest CT or a high resolution chest CT to further know what is the problem at hand. But we can tell that at the very least there's multiple cavitary lesions within the apical region or within the right upper lobe region of the lung. All right, so this could mean a number of various things. Now let's look at this one. Now this one shows the incidental finding. If I told you this patient has fever and weight, or let's say this patient has dry cough and weight loss, and let's say he's a smoker, and then in this case you found the incidental finding that, or let's give you another patient presentation. Let's tell you this patient has meiosis and ptosis and anhidrosis. He has Horner syndrome. You did a chest x-ray and you found this finding. So now you know the cause. The cause in this incidental finding is Pancoast tumor. Everything looks normal, but you can see there's a soft tissue density mass within the apex of the left lung, and it looks to be pretty much compressing this portion of the lung near the cervical vertebrae. Again, you take a biopsy or you do a chest CT and you go from there. But we will assume from the patient's history, if we have a patient history, we will assume that the differential diagnosis, this is a case to be Pancoast tumor. This could be Pancoast tumor, this could be a case of TB, latent TB. This could be a case of aspergillosis. This could be a case of a whole bunch of things. Again, the patient history will tell you the diagnosis. Maybe this is Pancoast tumor, maybe something else. Now we look at case number 44. This is a clear-cut case of Kaplan syndrome. So pretty much a patient with rheumatoid arthritis. A patient presenting with symptoms of rheumatoid arthritis. You can see the ulnar deviation. So if a patient has symptoms of rheumatoid arthritis and the patient has presence of interstitial lung disease, so you can see here there's the presence of pleural plaques, or pulmonary nodules. Or this is more than likely to be pulmonary nodules. So you have 1, 2, 3, 4, 5, 6, 7, multiple pulmonary nodules. So if you have multiple pulmonary nodules with manifestations of rheumatoid arthritis, you think of Kaplan syndrome. They must occur both at the same time. They both must be active. If you have multiple pulmonary nodules, it might be malignancy. Or this could be pleural plaque. You don't know. This person might have he might have asbestosis, an interstitial lung disease that has progressed into mesothelioma. But this is more than likely to be pulmonary nodules with rheumatoid arthritis manifestations. Regardless of the case, rheumatoid arthritis with respiratory manifestations, you need to think of them both together as Kaplan syndrome. All right? Again, look at the findings, get the patient's history, you'll connect the dots. All right? So this is the incidental finding. Again, this is the same that we've seen before. The same finding from what we've seen before. This is a clear-cut case of pulmonary hypertension. You can see how they're enlarged. They're not lobulated in appearance. All right? Again, you need the patient's history to correlate with the chest imaging. If we look at case number 46, now we can tell what we've mentioned before about the valves. If you put an imaginary line, a vertical line, you'll see that the line, you'll see, if you put a vertical line, if you see anything below this line, you think of aortic and mitral valve. So this is the mitral valve from the front, and the aortic valve, sort of oblique in position. And this patient also has cardiomegaly. This patient also has a first lead pacemaker, the first lead being all the way towards the left ventricle approximately. So this is a patient who has a valvular heart disease. All right? So that's pretty much it for our case. Now, if we look at case number 47, case number 47 shows to me that this patient has a soft tissue density mass present within the right upper lobe. So if you have a soft tissue density mass within the apex of the right upper lobe, again, you want to think of Pank's tumor. You might think of TB. You might think of histoplasmosis, a whole bunch of things. All right, it's according to the patient's case. All right. Everything else looks normal. On top of that, you might see that the pulmonary vascular markings, they might be more visible. But again, in this female patient, what we want to mention is the obvious is this is a case of Pank's tumor. All right? Maybe she has TB, maybe she don't. Maybe she has Horner syndrome, maybe she don't. Maybe she has lung malignancy. We don't know. We will need chest CT and the patient's history. All right? So Pank's tumor, maybe. And we have pulmonary vascular markings that are visible here. It could mean pulmonary congestion, probably. Now we look at case number 48. In case of case number 48, we can see the incidental finding here, and there is mediastinal widening. So the mediastinum typically is narrow. Remember, it's typically narrow. There's no widening of the mediastinum. It could be focal. You could have focal mediastinal widening, or you could have diffuse, meaning there's widening of the mediastinum from all directions. If there is widening of the mediastinum diffusely, you want to think of severe conditions. So it's bleeding. You want to think of bleeding. So something like aortic dissection. So in a known hypertensive presented with chest pain radiating towards the back, you might think with mediastinal widening. You might think of, aortic dissection. You might think of pulmonary anthrax, a bacterial infection. For example, this is with diffuse mediastinal widening, and we talked about that from before. All right? So mediastinal widening, where there's widening that is basically projecting outside this one and this one, you want to think of bleeding, most commonly aortic dissection. All right? If there is focal mediastinal widening, then you think of focal causes, mediastinal masses. But here we're thinking of bleeding because there is widening diffusely. All right? And here is talking about pulmonary edema, what we talked about before. In patients with heart failure, they might have normal pulmonary vessels. Then as there is more fluid going towards the lungs, especially if you have left-sided heart failure, you'll have interstitial pulmonary edema, which is presented with white lines. They call this curly B lines. If you heard them from before, curly B lines. Sometimes you have loculated pleural effusion. Again, this is at the earlier stages. And then at the advanced stages, you might be presented with alveolar, not interstitial, now alveolar pulmonary edema in a bat wing-like configuration. So this is just revising the stages of pulmonary edema. Again, this is talking about the curly B lines, which are straight white lines near the ribs. All right? Which is due to thickening of the interlobular septae. And here we're talking about the septal lines. Again, if we zoom in this region, You can see the septal lines here. 1, 2, 3, 4, 5, 6, 7, 8. They're very, very subtle, the curly B lines. But they tell you that this patient has heart failure, or the earlier stages of heart failure associated with pulmonary edema specifically. Now, if we look at case number 49, here we have a young patient with cough. All we want to mention is this, all we want to mention is the positive findings. Here, this patient has nipples. Again, patient may have a pacemaker. Patient may have a valve replacement. Patient may even have a piercing in his nipples. And again, anything of metallic structure will appear as very white. They will appear as very dense in a chest X-ray. So we just want to mention that this patient has piercing because this chest X-ray is not complete, all right? We just want to say that this patient has piercing and nothing else besides that. We can see that the claustrophrenic angles are normal, the diaphragm, they're normal, the lung parenchyma from this incomplete picture, they're completely normal. Now for the final case, or almost the final cases. We're almost there. In case number 50, we're talking about chronic shortness of breath. If you notice here, there is a abnormality. The right hemidiaphragm, they're normal. The claustrophrenic angle, they're normal. The lung fields, they're normal. The mediastinum is almost normal, but if you notice in the heart itself, you see the right heart border, it is normal. But if we look at the left heart border, you see the left ventricle, you can clearly tell it's normal. You can see the borders of it. But if we look at the left atrium making up the upper portion of the left heart border, it is enlarged. It is very much enlarged, and it is projecting, this concave in appearance. It is projecting towards the lung parenchyma. So we have a clear-cut case of left atrial enlargement. All right, left atrial enlargement. You can see there's nothing wrong with the aorta. This is the aortic knob, the descending aorta, and the ascending aorta. They're normal. So we have here a left atrial enlargement coming with this appearance. And please remember, oftentimes when you have focal widening of the heart border, when there's focal widening looking like this, please remember, this is due to enlargement of the chamber, not because of hypertrophy. And what I mean by that is if you have left ventricular hypertrophy, there will be no widening of the left ventricle. All right? If you have left atrial hypertrophy, nothing will happen. In order for widening of the heart border to occur, there must be enlargement, all right? So if you have left ventricular enlargement, it will appear on the chest X-ray, but it's not there on this one. If you have left atrial enlargement, then it will appear on X-ray. Please keep this as a principle. With enlargement, there's accumulation of fluid, and it will project towards this side, all right? If you have hypertrophy, nothing will happen. It will appear normal, all right? So this person has a left atrial enlargement specifically, and left atrial enlargement could be due to mitral stenosis. It could be due to mitral stenosis. That's the most common cause. So you'll order often case an echocardiogram. All right, to know if this patient has a valvular heart disease, for example. All right. Also, patient may have a ASD. Patient with atrial septal defect, they might have a left atrial enlargement. You can also keep this as a differential diagnosis. So again, the positive finding here is left atrial enlargement, only this one. Everything else is normal, and this might have a number of differential diagnoses as to why. So this is not hypertrophy, this is enlargement. If we look at this case, again, young patient with weight loss. Now, if you notice an incidental finding here, and a patient presented with weight loss in this female patient, you'll notice that the breast is, it's removed. Look at the breast. Look at this. The left one is intact, but the right side is not intact, or it's gone. It's removed. So this patient had a right-sided mastectomy, This explains the weight loss. He had a previous sign of malignancy. He removed the right, she removed the right breast, and now we did a chest X-ray, and now we want to look for pulmonary nodules. All right, you always want to zoom in for pulmonary nodules if there is any. Maybe this one. This is more than likely to be a pulmonary nodule. All right, this one might be a pulmonary nodule. Again, you'll order a chest CT to further confirm your case. All right, or even zoom in. But I'm having a suspicion this is a pulmonary nodule. You'll need a previous chest X-ray or order a chest CT to look for pulmonary nodules. Because remember, this patient is young, presented with weight loss. She removed her right breast. So you want to look for lung cancer, or lung metastasis from a previous breast cancer, like ductal carcinoma, for example. All right. So there's no specific diagnosis. You just want to, put your eyes on everything. You want to look for obvious stuff like mastectomy. All right. This is pretty much it. Now we come to this, and this is the final case for our final video. If I have a patient with hypertensive known, presented with recurrent chest pain, and I look at this chest X-ray, what is my most likely diagnosis? This is a very clear-cut case diagnosis of hiatal hernia. So hiatal hernia or hiatus hernia is very obvious. Oftentimes the stomach, it should be here, but the stomach, it's pulled upwards. Why? Because of a whole bunch of things. So in hiatal hernia, pretty much the upper portion of the stomach, what they call the apex of the stomach, it's pulled upwards along with the esophagus. And what that means is the stomach will be pulled upwards. And how this will appear on chest X-ray, how it will appear is that the stomach, it will appear in the place of the heart. So if you see, in summary, if you see the presence of air fluid level within the heart, you must think immediately of hiatal hernia. All right, so hiatal hernia is by far the most likely diagnosis. All right, because there's pulling of the heart, and on chest X-ray, on a PA view, because of overlapping of the structure, you will see hiatus hernia in the form of air fluid level within the area of the heart. All right, that's pretty much it for this case, spot diagnosis. Again, this is showing what hiatus hernia. You can see an air fluid level within the area of the heart. So this patient has hiatus hernia. All right. Remember, X-ray shows a lot of overlapping structure, so which will show completely different appearances from what you think. So you need to think logically. All right. That's pretty much it for hiatus hernia. That's pretty much for the cases. We pretty much finished from the cases. I hope you enjoyed from these videos, quickly revising the spot diagnosis of chest imaging in internal medicine and even in surgery. And I'll see you in the next one.